Now that we've examined some vaccine specifics, let's take a look at some common problems with vaccine administration. The first administration issue is the diluent. Dry vaccines that need to be reconstituted must be used together with a diluent specifically made for that vaccine. A vaccine reconstituted with the wrong diluent is not viable and therefore cannot be counted. One way to minimize confusion is to store diluents together with their proper vaccines. Some vaccines come with a diluent in the same box. Keep these boxed up together. Other vaccines, like MMR, have separate boxes of diluent. These should be stored together with vaccine in the refrigerator and, in fact, can be damaged by temperatures higher than room temperature. The dosage is important too. Most vaccines are given with a 0.5 milliliter dose. The exceptions are flu vaccine for babies 6 to 35 months old, which is a half-size dose at 0.25 milliliters, and adult hepatitis vaccines, which are given in a 1 milliliter dose. Some reconstituted vaccines are slightly more than 0.5 milliliters because the dry solid adds to the 1/2 milliliter of fluid. The whole amount of fluid in the reconstituted vial should be given even if it is more than 0.5 milliliters. Now I'd like to add a quick note about expiration dates. Vaccine can still be given on the date printed on the bottle. It is the day after that date that it expires. For example, if the vial says August 15th, it can still be used on the 15th but must be wasted on the 16th. If only a month and year are printed without a specific date, the vaccine can be used on the last day of that month and must be wasted on the first day of the next month. Some nurses use bacteriostatic saline and know it must be wasted 30 days after opening, regardless of how much was used. Multi-dose vials of vaccine don't expire until the date shown on the vial, even if they are assessed more than 30 days ahead of the expiration date. Single-dose vials expire 24 hours after the lid is removed. There are no preservatives in single-dose vials. Light damage is another issue. Too much light can inactivate a vaccine, creating an issue for industrial storage refrigerators with glass doors. Keeping vaccine in the original boxes can help minimize the risk of too much exposure to light. Certain flu, HPV, meningococcal, varicella, and MMR vaccines, and all rotavirus vaccines, can be ruined by exposure to light. Because storage conditions including light exposure may vary by brand, it is important to read package inserts to avoid wasting vaccine and losing money. This is an important consideration while the vaccine waits in the syringe to be given, as well as in storage conditions. Another administration consideration is the stability time in a syringe. Some vaccines are stable longer than others once they are drawn up. A vaccine is considered drawn up once it is drawn from a vial into a syringe, or, in the case of pre-filled syringes, once a needle is attached to the syringe. The CDC recommends using all drawn-up vaccine by the end of the clinic day. No drawn-up vaccine should be stored overnight. Additionally, single-dose vials of MPSV, MMRV, varicella, shingles, DTaP-IPV-Hib, and DTaP-Hib have shorter viability and must be used within 30 minutes of being drawn up. MCV should not be drawn into a syringe until immediately before use. It's also important to give vaccines the right way. Hepatitis B vaccines must be repeated if not given into the muscle. Most vaccines are given intramuscularly, with the needle perpendicular 90-degree angle to the muscle. IM vaccines should be spaced at least 1 inch apart if more than one is given in the same muscle. MMR, varicella, shingles, and MPS4 are given subcutaneously into the fat under the skin with the needle at a 45-degree angle. According to the CDC, because there are no large blood vessels in the recommended sites, aspiration before injection of vaccines, example, pulling back on the syringe plunger after needle insertion before injection, is not necessary. There was less evidence of pain when aspiration was not done. Polio and adult pneumonia vaccines can be given either IM or sub-Q. Some flu vaccines can also be given nasally or into the skin intradermally. For infants, give IM vaccinations in the long vastus lateralis muscle on the outer portion of the thigh. For older children and adults, use the deltoid muscle of the arm. Please note, vaccines should never be given in the gluteus muscles. Needle size is also important. Intramuscular needles should be at least 1 inch long. Although it is not always necessary to use the full length of the needle, 1 inch is appropriate for most patients. 5/8 inch needles also have been shown to cause more local irritation when used for intramuscular injections. Some patients with thick fat over their muscle will need a 1.5 inch needle to get the vaccine well into the muscle. Vaccines are not very viscous, so needles as fine as 25 gauge can be used. Documentation of vaccines is very important and requires several parts. The patient or parent should be given the Vaccine Information Statement, VIS, before the vaccine to allow them time to ask questions. Note that the date the VIS was printed needs to be part of the clinical charting. Also, if counseling is charted, it becomes a billable service. Thankfully, there's help with documentation. The Ohio Statewide Immunization Database, IMPACT-SIS, can help with documentation by providing simple daycare and camp forms which summarize a child's immunization history and provide space for documenting a basic physical exam. A needle of any size can cause distress in children and adults alike. Children don't usually like it, but restraint is important for the safety of the vaccine giver and for the vaccine to be given effectively. You can help parents use the comfort restraint to immobilize the child's arms and legs in the most comforting way possible. To achieve this, wrap the parent's hands around the child to hold the arm being immunized. The child's other arm should go under the parent's armpit and around the parent's back. The child's legs are held between the parent's legs. The child will need to be switched to the other side to give vaccinations in the other arm. A modified comfort restraint seats the child facing forward so both arms are accessible, but it makes it easier for the child to see the needle coming. It also can be harder for the parent to maintain the hold if the child is struggling. Distractions such as engaging images or participatory activities can minimize a child's anxiety and pain. For example, on the count of 3, have the child blow on a pinwheel in the parent's hand. Now, let's talk about another important topic: storage and handling. In this section, we'll address issues that can affect vaccines in the refrigerator or during transit. Transporting and shipping vaccine can be tricky. Refrigerated vaccine must be kept between 2 to 8 degrees Celsius, but the temperature can't drop below or it might freeze. Some clinicians mistakenly pack vaccine for travel with frozen cool packs to keep the vaccine from getting too hot. This poses a very real risk of freezing the vaccine. When the frozen pack and the liquid vaccine equalize their temperatures, it's much more likely that the larger mass of the frozen pack, which is probably at about minus 20 degrees Celsius, will freeze the vaccine than that the vaccine will raise the temperature of the frozen pack. To transport refrigerated vaccines safely, coolers must have a minimum of 1.5-inch thick walls and a lid for insulation. Any insulated container that has been validated for the shipment of childhood and adult vaccines is approved for vaccine transport. These containers may include styrofoam coolers. Use refrigerated cool packs to maintain the vaccine temperature so there's no risk of freezing. Place refrigerated gel packs, not frozen packs, on the bottom of the cooler. Make sure the bottom surface of the cooler is completely covered. Next, place at least 2 inches of crumpled paper to separate the refrigerated gel packs from the product. Place the product in the center of the cooler. Cover the product with another 2-inch layer of crumpled paper on both the top and the sides of the vaccine to prevent it from shifting. Place refrigerated gel packs, not frozen packs, on top of the crumpled paper so the whole top surface of the cooler is covered with gel packs. Place the lid on the cooler and seal it shut with tape. If the trip is long and frozen packs are needed, use as few as possible and buffer them from the vaccine with at least 1 layer of refrigerated cool packs. Always follow proper security measures when transporting the vaccine. Never store vaccine in freezing temperatures, 32 Fahrenheit, 0 Celsius or lower. Never place ice or frozen gel packs directly on product. Placing chilled gel packs on the product will keep temperature stable as the cooler is opened repeatedly during use. Outside temperatures, the length of the trip, and the frequency of opening the cooler can make it hard to guess how much is too much. Include a thermometer next to the vaccine in the cooler and log the temperature hourly so you can adjust the contents if the temperature starts to get out of range. Vaccine that reaches 0 degrees Celsius is ruined by changes at the molecular level, even if the water in the vial still looks liquid. Additionally, providers are being encouraged to avoid dorm-style refrigerators for vaccine storage. Small dorm units stay warm for too long when opened, can freeze vaccine over the weekend, and can't keep the tiny freezer compartment stable enough for frozen vaccine. The best solution is a laboratory or pharmacy refrigeration unit, but since these can be prohibitively expensive, many practices use common household refrigerators with separate refrigeration and freezer compartments. For providers using VFC vaccine, new policies make the practice financially responsible for vaccine loss to poor storage units. In addition to having the right refrigeration unit, monitoring is important for vaccine safety. The minimum for monitoring vaccine temperature is to use a min-max thermometer to validate the highest and lowest temperatures since the last check. The temperature and min-max should be logged twice daily. Today, new technology allows for up-to-the-minute constant logging of vaccine temperatures with data loggers. Some units include the ability to notify providers remotely if the vaccine goes out of range. If there is an issue due to a power failure, the ability to tell a manufacturer exactly how much and for how long the vaccine temperature was out of range can prevent expensive wastes. However, if the worst happens and the vaccine temperature goes out of range, take the following steps. Log the amount of time and temperature that the vaccine was out of range. Move the affected vaccine to stable storage and mark it so it doesn't get accidentally used. Call the manufacturer to see if the vaccine can be used or must be wasted. Document the whole process for practice records. Where you store vaccine in a refrigerator is important for viability too. Never store it in the door racks or in the drawers. The temperature can vary in those areas. Keep the oldest lots in front so you don't accidentally let vaccine expire in the back row. Keep filled water bottles in the empty airspace of the refrigerator. This will help the refrigerator cool down quickly again after the door is opened. Allow space for air to circulate vertically to even out the temperature throughout the refrigerator. And if the unit has a freezer compartment on top, don't put vaccine on the top shelf where the cold air comes down from the freezer. This area can freeze vaccine. Color-coded bins also can be used to store cartons of vaccine to separate it by sources and other logistic distinctions. Again, keep vials in the original cartons to minimize errors, keep diluent matched to dry vaccine, and protect vaccines from light.